Welcome to All Things Policy, a daily podcast supported by Pragati, a flagship media initiative of the Takshashila institution. We're a bunch of policy nerds based in Bengaluru, and we like to bring a fresh perspective to Indian affairs and an Indian perspective to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello, welcome to All Things Policy. This is Megha Pardhi. I'm research analyst at the Takshashila institution. Today we are talking about India's approach to malnutrition. And to discuss this topic, today we have with us Dr. Harshit Kukreja, who is also research analyst at the Takshashila institution. Welcome, Harshit.
Hi, Megha. Thanks for having me.
So, Harshit, before we talk about India's approach to malnutrition, I'd just like to quickly inform our listeners about Takshashila's School of Public Policy. So, as some of you might already know, Takshashila Institution is an independent and non-partisan think tank and a school of public policy. We have education programs that last from 1 semester to 1 year, and they are tailored specifically for people who are interested in policy analysis and policy making. They are online and you can take them from anywhere. So applications for admissions are now open for a 12-week graduate certificate program in public policy, defense and foreign affairs, and technology and policy. Deadline for application of September 2022 cohort is 27th August. For more information, visit the link given in description. So coming back to India's approach to malnutrition, I have a very basic kind of doubt first. What are the different types of malnutrition? Is just because in general, when we speak of malnutrition, we think of at least I think of, a very little baby who's very undernourished and probably very hungry, with bones, very skinny and bones are visible. And that kind of picture comes to mind. But I have heard that there are also different types of malnutrition, but you'd know more about that.
Yeah, Megha. So that is a very common picture which people usually have. That is one aspect of malnutrition, and that is what had been the dominant malnutrition aspect, the category of malnutrition in India and other developing countries for at least 2 decades back. But now we are moving to the other categories. Basically, there are 3 categories of malnutrition. First is undernutrition, which you very rightly described. This is basically when there's a deficiency in calorie intake and there's a deficiency and the energy used is more and the calorie consumption is less. So because of that, the body goes into undernutrition. You are not able to get appropriate levels of nutrition. The second category is malnutrition related to micronutrient. Micronutrients basically means iron, vitamin B, folic acid, basically B12, folic acid, and other things. So this is what, when we talk about anemia, we talk about undernutrition related to micronutrient deficiency, malnutrition related to micronutrient deficiency. So the third category is of the other extreme. So this is the first one was malnutrition related to undernutrition, that is deficiency. And Megha, take a guess. What is the third category?
Overnutrition, maybe?
Yeah, you can say you can call that overnutrition. It is basically malnutrition related to obesity, related to diseases such as heart disease, hypertension, diabetes. So these are the basic 3 categories. One is at one extreme of the seesaw, at one end of the spectrum. That is where there's a deficiency in basic macronutrients. One end is where there's a excess of macronutrient. This could be because of a variety of reasons. This could not. This is not only related to intake, but can be because of a variety of reasons. Maybe because of some endocrine issue, maybe because of a metabolic problem, maybe because of some pre-existing diseases. The intake, even though may be appropriate, but you get all those adverse effects and all those diseases related to obesity and non-communicable diseases.
Okay, so to put it simply, malnutrition is not just a lack of food, it's also caused due to range of other issues. So even though you are taking enough food or if you're eating even more food, that doesn't mean that you are properly nourished. Am I correct?
Yes. So it should be right food in right quantity.
Okay. Yeah, so of course, even though I kind of knew about a few of those things, but exact definition of different types of malnutrition, even I was confused. So thanks for that. What are the other major nutrition related issues in India, apart from people not knowing types of malnutrition?
So India is the major issues. I can say one of the major issues is India is now facing the double whammy of malnutrition. At one end, we have people who are not getting enough food, and at the other end, we have people who, because of eating basically access to macronutrients, they are now getting into a whole range of non-communicable diseases which are affecting everything from a 5-year old to a 60, 70-year-old person. So because of that, the burden of non-communicable diseases, that is heart disease, hypertension, diabetes, even in COVID, if you were you came in, your BMI was somewhere plus 30, the risk of death, the risk of adverse reaction grows exponentially. So this also brings a whole lot of problems. And somewhere around 60% of all deaths have as a confounding factor, or as one of the factors, obesity related malnutrition. It plays a major part in causality of deaths and also of mortality and morbidity.
Okay, so basically we are facing challenges from both ends. Not enough food and too much of food, right? So what do you think India should do to tackle these issues of malnutrition?
So India, we would have been correct 15, 20 years ago, or maybe even 25, 30 years ago, when we were focusing heavily on undernutrition, focusing heavily on people not getting enough food. That is also an important part today. But we also have to shift our focus to obesity related malnutrition. We also have to shift our focus to prevent chronic diseases, prevent lifestyle diseases because of increased urbanization, because of changes in food, because of packaged food, because of too much sugar in food, because of increased salt intake. All these things have contributed to the third category of malnutrition being a major player in disease burden, being a major factor leading to an increase in disease burden. We currently don't have a we the government is not focusing a lot on this part. Our focus is on the undernutrition part. We don't want to shift our focus from the undernutrition part to the overnutrition part, but we want some focus, some resources also allocated to the obesity related malnutrition. And one, I think, major thing I would like to point out is we depend heavily on the public. Basically, there are two approaches to nutrition improvements a state can do, a government can do. Basically, anybody can do for its population. One is the public or the community nutrition approach. The other is the clinical or the individual approach. So, on a public or the community level, is where you make nutrition interventions to improve the population health, to improve. For instance, you add iodine to salt. We add iodine to salt to prevent a goiter, to prevent thyroid dysfunction, to prevent certain intellectual disabilities. And that was a well done public or the community nutrition approach. And it was because we found a need. We found a way to tackle that need. It was cost effective. And we also monitor how much iodine we're giving, how much is the urine iodine level, and things like that. So it is an important part. But what we as a country are doing wrong is the central government has said that by 2024, they will fortify all rice provided to or provided via the government infrastructure with iron, folic acid, and vitamin B12. So what they'll do is they'll take rice, they'll add iron, folic acid, and B12. They'll crush it. After crushing, they'll add everything, and then they'll make it to similar rice-looking sort of like kernels, and then they'll mix it to some time around. I don't remember the exact number, but it was somewhere around 10-15% to the normal rice, and then distribute it via the distribution network. So there are a lot of problems with this approach. First of all, the deficiency of micronutrients such as iron, folic acid, and B12 varies heavily across areas and varies heavily across age groups and varies heavily across populations. So it is a very bland. It is like using a big hammer to like put in a small nail. You cannot do that. And the other thing is, if you are giving micronutrients to people who are not deficient, you will cause problems of access. So instead of you are trying to cover that gap between deficiency and the normal range which we want, and you're covering that gap, but you are pushing people in the normal range to the access range. So this is a very wrong way nutrition interventions have been done.
So, Harshit, if you think, okay, first of all, let me just, go back and try to summarize. So, you're basically saying that we need to stop Americanization of food availability, like a lot of sugars and a lot of processed foods. Basically, we need to avoid that, right? And there are some drawbacks in our public nutrition approach. So, now what do you think we can do to remove these drawbacks, or what can be done to address these issues which you mentioned?
Yeah, so not correctly Americanization, but it is basically westernization of our diet. We have too much, we now are having too much sugar, we are having too much salt, which is not needed and which is quite harmful. That is not a diet we should be aspiring for because of the changes in our lifestyle, because of the changes in our exercise patterns, because of the changes in how we live right now, how we have shifted to cities and everything else, the increased urbanization. This lifestyle, this diet will bring a lot of sort of adverse effects with it. So the better approach to at least some kind of nutrition problem would be the clinical or the personal approach to malnutrition. So in this, we try to focus on the individual. You start this at the healthcare facility and you try to modify dietary factors of outpatient and hospitalized patients. So this way you try to tackle malnutrition at a clinical level, at an individual level. And what you try to do is when you get patients of lifelong diseases, of chronic diseases like diabetes, heart diseases, hypertension, you try to modify their diet instead of trying to, for instance, advocating for restriction of salt intake across the spectrum. Obviously, people should eat less salt. The Indian diet has a lot of salt, which we don't require and which is basically harmful. But you cannot make it a successful public intervention at a community level. We'll have to do it at an individual level. So what you try to do is you try to bring those people who are already sick, or basically the chronic patients, and try to modify their nutritional factors. In India, nutrition as a clinical aspect has no sort of like no importance. A lot of people don't give them importance. Even if you go to a good hospital in a tier one city, the doctor or maybe the paramedical staff will not stress too much on nutrition. They will give you a sort of a generic nutritional advice, which would be eat less oil, eat less sugar, eat less salt, but that does not work. So when we try to modify these factors at an individual level, and then we try to reduce, this would help us in reducing the obesity related malnutrition. So because we have reduced malnutrition at that level, and that when you're talking to chronic patients and you have a focused individualized recommendation, this will help us in preventing progression and recurrence of diseases, because this is becoming a huge problem for us as a country as a whole.
That's very interesting approach. So let's take a break at this point and we'll discuss further issues after the break. Welcome back. In today's episode, we are discussing India's approach to malnutrition. Before break, we discussed different types of malnutrition and what are the major nutrition related issues in India. And Harshit very nicely explained that we have both problems of not having enough food and also overeating. And we also discussed some of the key approaches to tackle malnutrition in India. For example, a public nutrition approach, what are its drawback and advantages of clinical and personalized nutrition approach. So, Harshit, what do you think are some of the key barriers or problems in addressing the nutrition related issues in India?
So nutrition as a whole, if you look at, so we don't have any what I call as outcome indicators. We don't measure outcomes. In a lot of programs, our focus is only on uptake. So we see how many children are maybe getting eggs in their meals or how many children are taking the meals, but we are not actively measuring. And even if we are measuring at a different center, we are not collating that data with eggs. So we are not measuring how has the malnutrition improved because of the eggs. How has maybe not eating those eggs like affected the children? We also don't have uh, the next problem I think would be data collection. Data collection. These are all after the approaches we talked about. These are like a little micro level when you come to a micro level approach. So there's no data collection. There's no good data. even the National Family and Health Survey is good. It gives you a little idea about the trends, but it has like a lot of flaws. The questionnaire is too long. The data is insufficient to make concrete sort of like conclusions at a district level, leave alone block level or village level. The sample size is too small, and this is the only reliable recurrent data we get regarding health. This is also not good. So we also rely a lot on the Anganwadi workforce. They are very overworked, they are undertrained, and they're underpaid. So you don't get, and we try to sort of like get them to do everything. We want them to do nutritional activities. We want them to do maternal checkups. We also want them to do immunization. We also want them in COVID. We also wanted them to do vaccinations, to do door-to-door checkups, everything you want them to do. So they are very overworked, and the training they get is not up to mark. It's not sufficient, and they don't get paid so well. So if you're not getting paid so well, you're not motivated to work a lot. So and it is not possible to like do the amount of work they are supposed to do at such a wage point or such deficiency of resources. We also have, this is slowly getting better, but we also need to include local cuisines to our food programs. There were a lot of sort of small pilot projects run, and certain states did that. But if you, for instance, add things like coarse grains like ragi, jowar to the local, according to local cuisine and local uptake, you'll get much better results. And we also lag in adding evidence-based practices. So we don't run a lot of pilot projects. We don't update our practices. We don't like, we're not as quick as we want to be. We just, we have certain sort of like aspirational districts in which a lot of things are be done. But there's no, for instance, if I want, for instance, the latest Lancet report 2021 said that small quantity lipid is fat based nutritional supplement will do a lot of good in fighting malnutrition. So instead of like doing certain pilot studies, seeing what is a cost effective lipid based nutritional supplement we can use, what oil can we use, what should we use, refined should we, whatever, how do you process it, what is acceptance according to local culture and everything. We are not doing anything. And what usually the government does is 5 7 years after these reports comes and after a lot of people, a lot of organizations and a lot of countries put them into their programs, we do a sort of a namesake pilot study somewhere, and we just integrate that into our programs instead of doing local level studies and being ahead and trying to modify according to new changes and getting better data and seeing how it is working, that the feedback loop is not completed. With the launch of Poshan 2.0, there has been convergence and coordination between departments and ministries, but we'll see how it will work down the years. We hope for the best, but I think issue regarding coordination between different ministries and departments is like quite a difficult task.
You spoke of over reliance on Anganwadi workers. That reminded me of my own Anganwadi days when I used to carry a little small box, and then we used to go and collect. If we used to call it chana chatpati, I don't know what others got, but I remember that was one of my joys, highlight of the day. I got the chana chatpati and kukri. Yeah, but I do agree that we do rely a lot on Anganwadi workers. I still remember. So my mother is a school teacher, and I still remember. Anganwadis are generally connected with Jilla Parishad schools. So her telling me that there are a lot of things today, then and they had to rely on Anganwadi workers a lot for even day-to-day school functioning. Even the midday meal program, a lot of help was taken from Anganwadi workers. Yeah, also, I think one of the thing is for midday meal was, I think, also introduced as a, uptake oriented approach. Am I correct?
Yeah, so it's not basically the approach, it's how you measure the outcomes. We're not measuring outcomes, we are just saying, for instance, obviously there are outcome indicators, but they're not used, and maybe the hospital or the PHC, the primary healthcare center, which is measuring them, the data is not connected. So you don't know if child A, after having the midday meal for 6 months, has he gotten better? Has his health issues been resolved? Or is he better in studies? Is his cognitive abilities? Has he gotten more? Is he able to concentrate more? But we don't have that correlation. We are not able to correlate because we don't measure that. And yeah, midday meal has been very successful, but the outcomes are measured on the uptake. Uptake only. That we only measure outcomes as, for instance, 70% of the children in the district are using midday meals.
Okay, so basically we don't measure nutritional outcomes, we measure course outcomes, like what's the coverage of meal. Okay, so now you mentioned that clinical or personalized nutrition approach is one of the best approaches to tackle this, malnutrition issue. So as an individual, if I think of myself, like this is slightly off topic, but what type of
So the
diet do you think I should follow?
So the best diet to follow, the best diet to emulate would be the Mediterranean diet. So the Mediterranean diet is basically what they follow in Greece, Italy, France, Spain, somewhere in the Balkans, around that region. So that basically includes high consumption of olive oil, legumes, unrefined cereals, fruits, vegetables, certain moderate consumption of fish, cheese, yogurt. They also have what the Mediterranean diet, a lot of international organizations recommend is a moderate wine consumption, and they don't recommend a lot of non-fish meat products. So this is the best diet you can follow, and this is what, if we are able to, I don't think that is possible, but if we are able to move the population's diet into one direction, this should be the diet we should aspire to.
I feel like you're an Instagram influencer trying me to, convert into a Mediterranean diet fad person. But okay, I'll take this with a pinch of salt or maybe a pinch of chickpeas. But this is a good advice. I also I try to follow as healthy diet as I can. But of course, it's not as strictly Mediterranean as I could make it. But anyway, thank you so much. This has been a very enlightening discussion. Especially, I did not know that overeating is also malnutrition. And a lot of other things we discuss in this episode today. For example, how we do not focus on, we don't measure outcomes of our nutrition related projects. We don't have enough data. We rely overly on Anganwadi workers. We don't include our local cuisines into it. Rather, we should include our local cuisines into food and nutrition programs, and we should also adopt evidence-based practices. So thank you so much, Harshit.
Thank you so much, Megha, for having me. This was a good conversation, and this was, I think, a better attempt of mine to inform like our listeners of malnutrition in India. Thank you so much.
If you liked our show, don't forget to check out other interesting podcasts on the IVM network. You can tune into them on the IVM Podcast app, ivmpodcast.com, or wherever you listen to your podcasts. You can also follow IVM on social media. The handle is @IVM Podcasts on Twitter, Facebook, and Instagram. And hey, if you'd like to dive into Takshašila's research on technology, strategy, and economic affairs, check us out at our Twitter handle @Takshashila INST or our website takshashila.org.in.